Good evening. Welcome back to Expert Insights. We are on the subject matter of hope and health in the Philippines, and hope and health, a relationship. And our second guest here, Dr. Marife Yap from the Ateneo School of Medicine and Health, the Associate Dean. Dean is here to talk to us about health, and we finished having a discussion with Fred Lewis and HopeNet. So, Dr. Marife Yap, welcome to Expert Insights po.
Thank you.
Sir, Ma'am, sorry. My apologies. Tell us a bit about the condition of the health status in the status of health in the Philippines, the big picture.
Well, to put it simply, there are many things that come into play. The Philippines is a country that has some development, and therefore we are confronted with problems of illnesses from developing countries, high blood, heart disease, etc. But together with that are the older diseases that haven't been eradicated, which are infectious in nature.
Such as?
Well, the infections of the lung, the pneumonias, the diarrheas, and other infections. What we hear now with the floods and all, they are infectious diseases.
Right.
Dengue, leptospirosis,
wow.
which, if there are more preventive promotive programs, would have been of lower incidence and prevalence already. And, well, we're not saying that we like the other diseases better, but it's in technical terms, it's what they call, there is a demographic transition where there are changes from progress, and yet there are still the problems related to poverty, overpopulation.
Demographic progress?
Demographic transition.
Well, explain that.
Which means that as the country progresses and develops, and there is the introduction of new technology and more new ways of doing things, these bring about certain changes in diseases, patterns as well.
So the cycle, the relationship, and overall growth of a country.
Yeah, the other way to describe it is what they call the double burden of disease, meaning that the system, the health system of the country is confronted with a set of diseases that are driven by development,
or financial status of the country.
Yes, and also those that continue to be there brought about, see, these diseases like diarrhea before, or even tuberculosis, many years before us, even during the time of our parents or before that, they were challenges. They didn't know how to do it. They didn't know how to diagnose and treat it. But progress in medicine has made us or allowed us to be able to address these, you know, in a more definitive way. And yet they persist. Because of poverty, because of inability to reach out to many of the poor and the marginalized. And yet together with this, in many parts of the country where globalization and urbanization have come in, and development and economic progress, there have also been these other diseases called the lifestyle diseases. Diseases of behavior, diseases
AIDS.
Yes.
AIDS is
all
a
of those,
disease?
HIV, AIDS, and the heart diseases, and
smoking,
the cancers,
tuberculosis,
and diseases that are brought about by smoking, and things like that. So that's what you call the double burden. And the Philippines, just like in many countries, developing countries, we are confronted with
compared to
like
so many other developing countries, Asia, and also in the African countries, no? How are we doing? Compare us just to, say, Indonesia and Thailand. How are we doing in terms of...
We normally look at ourselves kind of similar to confronting the same problems as Indonesia.
Yeah.
But in Thailand, they're way ahead of us now, unfortunately.
In terms of?
In terms of addressing
the quality of health.
Their health system, the way their health system has been improved, the way they address the health needs of their people, the way their government prioritizes health. They are way ahead. You know, when we teach our students or when we talk to our partners in the community, we have this slide that shows us the GDP, the life expectancy, the number of children who die before they reach the age of 1 or 5 years old.
Belief systems.
Yeah, and when we look at it, because the whole theory is if you have a high GDP, meaning your country is more or less rich and the people have some economic capacity, then you're going to live longer or that lesser children die. But when you juxtapose the numbers of the Philippines to, say, countries like Vietnam or other Asian countries who are just now beginning to emerge, they're catching up fast. And our improvements are so slow compared to theirs. And so the whole point is, apparently it's just not the money. Apparently it's not just the resources.
It's probably the drive, the motivation, and the belief system.
Belief system, cultural, many social determinants of health, actually.
That is not a that's not a good piece of news. That's not a good
Well,
insight.
it's a reality, but it's not as if it cannot be addressed.
The government or any national programs that cater to this, that say, okay, we are now responsible for the whole. Is that the Department of Health plus?
Yes. Well, actually, when you look at health as a human right, it's placed in the constitution of all countries.
Right.
And therefore, it naturally becomes government's responsibility to ensure health, access to health for all.
Yeah.
And of course, the branch of government that's mandated to carry that out is the Department of Health. But as you know, here in the Philippines, since 1991, we enacted the devolution, the local government code, as we know it.
I need to understand what
the local government code decentralized the delivery of health services to the local government units.
Which local government unit means municipalities, barangays, or
cities, provinces. So
down to the barangay level?
Yes. So for example, let's just take the case of Quezon City.
Yeah.
It is really the Quezon City government headed by the city mayor,
and
who's the chief executive officer for the delivery of health services for the constituents of Quezon City.
So does that mean that there is no national policy, or there is a certain guideline saying that?
The local government code stipulates that the national government provides technical policy direction. They kind of like are the local version of the World Health Organization that sets the tone for the general health policy directions for the world.
So any other major policies or laws being drawn to change what is the current status of health?
Well, what is very obvious in the country, in the Philippines, is the inequity in access to health. Meaning
like a person making 15,000 pesos doesn't get the same benefits as the person making 200,000.
Or at the same time, the person who does not earn an income regularly or who does not have money in his or her pocket goes to a hospital, goes to a public hospital and expects to get free services for everything. But because he or she doesn't have the wherewithal to do it, doesn't get anything but needs the service. Whereas somebody who maybe is a middle income earner or maybe earns a little bit more than this person, because he has the knowledge, because he or she has the capacity to access, then he or she gets it, even if he or she doesn't need it as much as the poor person. And therefore, this is manifested by long queues in the office of the mayor, long queues in the office of the governor, asking for
crowded hospitals.
And crowded hospitals asking for free service.
I have been to PGH. A couple of years ago, my driver's son had an accident, so we had to take him there. And well, I feel PGH is doing good with what resources they have. It's a huge complex system, but the number of people there, the number of patients, and probably the quality of resources that they had, I thought, man, this needs work. So this is just the PGH down in Taft. There are, I'm sure, many more government hospitals across the nation. These are funded by local governments, these are managed by local governments, or these are nationally managed and funded?
The health system of the Philippines is a mixture of a regionalized system as well as an open system, meaning to say you can choose where you want to go to seek services. Now for government, the Department of Health still handles the so-called national hospitals. They did not get devolved, meaning they get their funds.
That PGH is a national hospital.
PGH is a national hospital, but it is autonomous.
Hospital
ng Makati is under the city government of Makati.
All right. So that's why they require a residency proof of Makati.
Yes. So the Jose Reyes Memorial Medical Center, which is down in San Lazaro, down in Avenida Rizal Avenue, beside near the DOH.
Yeah,
that's a government hospital. That's owned and operated by the Department of Health.
So people from anywhere in the nation can go to that one and to PGH?
Theoretically, yes. But there are hospitals like the city-owned hospitals, some district hospitals, the provincial hospitals. They are managed by the local government.
I have been to hospitals in the States many years ago, 25, 30 years ago, and I have no idea, but at least the health benefits provided by the federal government are slightly much better than what they are here. What is the system there? Are you aware of that?
In the U.S.?
In the U.S.?
Well, in the U.S., it's a system where if you have the funds, you purchase insurance for yourself.
But they also have a government kind of a deduction that goes on.
Yes, yes. There is also the Medicare fund.
Yeah, yeah.
And the fund for the elderly, which are kind of forms of social health insurance. But in general, in the U.S., it's not a compulsory system. It depends on your capacity to pay and what kind of services you want to avail of. But of course, there are the veterans hospitals and some state-funded hospitals, which are more the social for certain sectors of society.
So in terms of the state providing health support, what do you think is the benchmark? Any European country, Germany or something?
Well,
what is the place to fall sick in?
All right.
What is the country to...
Well, from the vantage point of the demand side, meaning those of us who need care, patients.
Correct, yeah, yeah.
A social health insurance system like there is in Germany or in the United Kingdom, which is a little bit different from Germany, would be something that you would aspire for, because then even if you have no money in your pocket, you go to a hospital, you are not turned away, you are treated in the full range of services that you should receive.
Historically, I'm sure every country that is now considered developed was at a certain time in the process of improving. So how did they manage to bring about such a good system of healthcare? What was their strategy?
Well,
which of the countries can we cite as examples and follow?
Well, we normally like, because I speak from the vantage point of the Philippines.
Correct.
Okay?
Yeah.
And our system is very much like the American model.
Which is our political system is also the same.
Yes, which depends on a person's capacity, ability, and willingness to pay for whatever health services he or she thinks he or she needs. So you move towards a system where you actually make it more available to everyone. And therefore, that's moving it more towards what we say is having the social health insurance program work for the citizens of the country. And therefore, all citizens of the country have an access to a basic set of services.
That should be the status quo, that everyone should be able to access at least the minimum healthcare.
But that's not true in the country now.
Not happening. Now, Doc, let's talk about 3 laws that are on the horizon, or at least are being acted upon recently. One of them is the cheaper medicine law. Now, I'm an Indian, which I'm sure it's obvious, is it? Or it's not? Well, I'm an Indian, and actually, when I used to fall sick as a kid, it was pretty as 1, 2, 3, go to the doctor and he'll fix you up. There was no state-driven, there were government hospitals, but it was not expensive to take care of minor ailments like flu and stuff. But in the Philippines, it's way too expensive. And cheaper medicine law caters to that?
Well, the cheaper medicine law was implemented to address one of the biggest challenges in the health system of this country.
Cost of medicine.
Which is cost of medicine and access to medicines. And it has many facets. The cheaper medicine law is there to ensure that parallel importation happens, and parallel importation is that the government can actually import cheaper medicines.
So for a company, for an ABC corporation, a global company that's bringing drugs for tuberculosis, so that means if it's 1,000 peso a tablet, government can bring in something for 50 or 100 pesos?
Yes.
And these people will not have an issue with them? The private organizations will not have an issue?
Well, this is for government hospitals and institutions. Therefore, the market of ABC being a global corporation will be those that cater to the private sector. They can come in.
But in terms of efficacy, you call it?
Yes.
Is there at par?
Yes.
There's no issue?
They have to see, because of the trade liberalization, and also because the standards for determining the quality of medicines is now uniform across.
That's the department. That's now called the BFDA.
Yes.
BFDA?
BFDA.
Or is it called
the Philippine FDA?
FDA. It's called. They changed their name to FDA.
It used to be BFAD.
BFAD. Yeah.
Now it's the Philippine Food and Drug Administration.
Right. How about the anti-detention law?
Oh, the anti-detention law is really more to be able to ensure a sort of like a social safety net for people who had been confined in hospitals but who are unable to pay their bills, or those who need to be hospitalized but should not be asked to give a deposit before they are given the service.
Well, wouldn't that put the hospital in a difficult position? So if I walk into St. Luke's and I say, I have a little challenge here, and they admit me in. They don't need to swipe my card, need no cash, they take me in. And if I can't pay hundreds of thousands of pesos, what about them? What about the hospital? How do they resolve this?
Well,
look at it from the point of view of
yes,
the people who have it.
Yeah. Well, for those people, there are many kinds of mechanisms. Like normally, those people who'd go to private hospitals would be covered with, well, first the basic social health insurance called PhilHealth.
Yeah.
After which they would buy extra to top off what PhilHealth will not cover.
Blue Cross.
Yeah, or other private HMOs or health insurance, or maybe they're employed in an organization that has given them a health benefit plan. And after which, that's when the extras come in. And because it's their choice to go to St. Luke's, they have to be able to, because it's a transaction between St. Luke's and this patient.
So
or
no ordinary citizen people who can just walk in, can they, or can they not?
Well, they can, but then they, just like any business transaction, when you buy something, you know what you're buying, and you know how much it costs. I mean, that's the relationship for a private hospital.
But wouldn't they be put in an odd position that, hey, you can't pay now, you owe us so much, they will still let you go, so you can't detain them?
Yes, but they put in certain other measures.
What kind of measures would they put?
Notes and
that wouldn't help in the long run.
Yes, of course, many of the private hospitals have a lot of bad debt and a lot of liabilities and stuff.
Dr. Yap, tell us a bit about managing hospitals, strategic management. That's where your specialty lies,
okay.
No?
You should understand that in the Philippines, there are a fewer number of government hospitals. I think they're only a third, they comprise only a third of the total number of hospitals in the Philippines.
Yeah.
However, they have the most number of beds. They're fewer in number, but they have more
beds. These are private hospitals?
No, public hospitals.
Public, okay.
And therefore, there are about 900 private hospitals in the country, but they are as small as a 10-bed thing to 25 beds to 400 beds, 500 beds.
Yeah.
Now, you have to understand it that way because historically, these 10 beds, 25 beds came about because my mother and father are doctors. There is no doctor in our little town. Let's put a little extension beside our house.
Yeah.
It was well received. And now I'm taking over. Let's continue this legacy of my parents. Many of these things. And so the challenge there is that when you put up a hospital, the old way of thinking about this is if I'm a doctor, I have the brain, I have a good heart, and my intentions are pure, I'm going to make it run. The patients will come. Unfortunately, that's just not how
So it was a mom-and-pop hospital.
Many are. Many are.
Still are. So
and they are successful so that they invest in big-ticket items. They have big machines. They add more beds. But unfortunately, they still think the same way. You know, I'm good, I'm kind, I want to treat, and so they open their hospitals, in fact, to people perhaps who do not have the capacity to pay, and then they find themselves in the red, hemorrhaging because of that.
So these are little mom and pop shops.
Some are,
so
some have become big.
Ateneo is running a course to change the course of history in terms of mom and pop hospitals, is that right? So can you describe that course?
Well, even before there was the Ateneo School of Medicine and Public Health, of which I'm Associate Dean for Planning and Administration, is only 5 years old.
Right.
But prior to that, since the 80s, we've had a health program within the Ateneo Graduate School of Business, for which I'm also the director of the health unit. And that's where we've been that's the staging area we've used to connect to managers in the health sector to actually teach them how to be able to manage their hospitals well. Because it's a given in this country that it is still more acceptable that the leader of a health facility or even the Secretary of Health is an MD.
Say that to me again, please.
It's a given culturally that if you are to lead a health organization like a hospital or, you know, a health facility,
you need to have a background in at least
that's the higher prerequisite over an MBA.
And you're saying it's not necessary?
It is not necessary.
It has to be run like a hotel or
it has to be understood.
Another hospitality institute,
Yes, as an organization that has the same human resource issues, operations issues, finance issues. It is true that as a product, health is unique. But then there are many, many things we can learn from industry, from other sectors, efficiencies and all of that And if you look at it and just apply that new paradigm in running hospitals, that's what
Ibig sabihin kaya yan if you look at it from a commercial point of view.
Yes.
Now, Doctor, one question before we end this show. The government is, in many infrastructure needs, education, tollways, etc., is partnering with the private institutions. Can this be done in terms of hospitals or health benefits for the country?
Very much so.
Yeah. Could you give us a insight?
In fact, one of the simplest models of a public-private partnership is that private hospitals actually go out of their comfort zones to apply what they know, what has made them successful, and help build the capacity of public hospitals. Even in just systems, business process improvement, customer service. It's these new paradigms. It's this out-of-the-box thinking that they can bring to the public sector.
So it is possible, just as it is possible.
Very much so.
All right. So let's talk about this program of yours before we close the case. This is the programs that Ateneo is running. So would you like to flash this to the camera?
Well, basically, these are short courses that we run in partnership with our the Ateneo Center for Continuing Education. They are really targeted for health professionals or professionals in the health sector, doctors and non-doctors.
And they are called the three programs?
The series is called Healthcare Management Series.
Healthcare Management Series.
And part of the series is first we launch a strategic management for hospitals, which will run from November 7 to 12. This is to be followed by a quality assurance, quality improvement course, and then a process improvement course. If you notice, they are the functional disciplines of management.
I wouldn't know that.
And we're applying them.
Yeah.
So essentially, it's really bringing it into the context of the hospital and the healthcare system.
Right.
We're doing this because we really want to contribute in raising the bar and preparing our facilities to achieve universal healthcare reform, which is the administration's battle cry.
Good luck with it. I hope you fill
much.
the rooms, and I hope you change the state of healthcare in this country.
Little by little, we want to do it and create the ripple, just like the
Okay, so in terms of closing remarks, what do you hope for the Philippines? What's your future? What's your desire for the Philippines? What do you want this country to be in a matter of 5 years? What do you hope for it?
Well, I am a health professional, and I'd like that the Filipinos become more empowered, become more responsible for their own health.
That's what you want.
And claim what they want and work with government and private sector for it.
Claim what is their birthright. Fred, what's in your mind's eye for the Philippines? You are changing the world from children up. What's in your mind's eye? What do you want?
Well, that's it. I really believe in the kids. They're gonna make this whole thing possible, and we're just here to help the kids. That's the way I look at it. We build it, the kids are coming.
So bahala sila. Bahala sila.
We actually share the same thing. If you build, they will come.
Correct. So you build it for health, and he builds it for children. Fantastic. So thank you very much for being on Expert Insights. Good luck with your endeavor. Dr. Yap, thank you very much for being on Expert Insights. So that was Dr. Yap and Fred Lewis and talking about health and hope. And we'll see you next week. Have a great weekend. I'm your host, Raju Mandian. Keep watching Expert Insights every Sunday night. Good night and mabuhay.